like to invite the next speaker for the next topic, the ideal crystalloid, traditional versus modern balanced crystalloid. We have Dr. Susruta, my dear friend Susruta. Yeah, he's the director of critical care from Mamre Hospital, Salt Lake, Kolkata. Over to you, Dr. Susruta, for the next lecture.
Yeah. Thank you, Dr. Varghese, for a kind introduction, and I thank the organizers for this invitation. It's a nice place, nice audience, nice talks. Uh, uh, we have already seen in the last hot debate that we need both, perhaps. We need fluids and we need vasopressors. And I'd be going to the sideline that if we're really going for the fluid, what fluids should we consider? Yeah. Now it is almost decided that when we give fluids in patients with septic shock, we'd be choosing crystalloids. Colloids are no more preferred, or in very selective situations we use them. It's crystalloids, but we have to decide what crystalloids. Are they all same, or do we choose anything among the crystalloids? First, we'll take a short recapitulation of the physiology. You can see this is called a thing called a strong iron deficit, SID. This is principle of electroneutrality. So basically what we have body fluids, the major part of the positive ions are by sodium, and we have got other cations like potassium, calcium, magnesium, these are here. And here it's a major, but not matching the sodium is the chloride. And then we have got this weak anions like albumin, phosphate, and bicarbonate. So the difference between this sodium and the chloride is the strong ion. This is the strong ion, negative strong ion, and this is the positive strong ion. And the difference between two, this is called the strong ion difference. And this strong ion difference is usually maintained at 40. If this gets below 40, approaching 0, that creates problem because the body senses it as excess negative ions, so it tries to preserve positive ions, that is H ions, and then there is an excessive H ions which causes acidity, and that causes the hyperchloremic acidity. And not only that, excess chlorides, if they go into the kidney, this excess sodium chloride, it goes into a thing called a macula densa. And that induces macula densa to secrete adenosine. This is called a tubulo-glomerular feedback. And that causes low flow in the afferent renal arterioles and hence lower GFR. And that may cause kidney injury and even lead to kidney failure. So with this, sorry, this slide is slightly morphed. I'll read it out for you. This is one good trial from Belgium which showed that basically what we are thinking right now of giving bolus fluid, etc., that is our resuscitation fluid. Then we can also have maintenance fluid. Once the patient is stabilized, we give some amount of fluid for various reasons over the next few days. And then there is a thing called this nutrition's oral intake. Then there is a maintenance, and then there is a thing called a fluid creep. That is, we are giving a large volume of fluids to deliver the drugs, the inotropes, the vasopressors, whatever it is. They also come with some amount of fluid. So they studied for 5 years retrospective data and all ICU patients, and they went into minutest details about what fluid the patient was getting. This was interesting in the sense that your resuscitation fluid is only this much. The major 30% are taken over by maintenance fluid, nutrition and oral intake, and fluid creep, that is the fluid going with the medicines, etc. So basically what we are talking about this resuscitation fluid, and these are the blood products, smaller one. So this is very small, about 6% of the total fluids are as a resuscitation fluids, and these are all 30%. So when we are talking about this normal saline or balanced fluid or everything, we are talking about a maintenance. Sometimes we talk about also resuscitation, maintenance fluid, but we are leaving aside this altogether. So that is one part which you'll have to remember when we talk about crystalloids or fluids. So, and this ratio changes. This is day one when you have got a large amount of resuscitation fluid and a much smaller amount this feed, etc. But when you go to day 3, the same study, it showed this resuscitation fluid has come down to much less, maintenance fluid is much larger, and the patient has started taking food, oral feed, and that fluid is going there. The fluid creep remains almost same in both the slightly larger here. So that also will have to take not only the fluid, what fluid you are giving, but when you are giving that fluid. That's also very important in the course of the disease. Now we know we need to look into what fluids we have as crystalloids. These are the traditional fluids, and now we have got a thing called like Plasmalite. There are some other brands too, and you see that normal saline is nothing, not at all anything normal. It does not have anything normal about it. Its pH is 5.5, very acidotic. Osmolality is 308 on the very higher side. Sodium is 154, much higher than body sodium level. Potassium is it does not contain potassium, and the chloride is also much higher. Same, that is this thing. Ringer's solution, Hartmann solution, they are also low pH. They have got less sodium, nearing to body's normal thing. This has got high chloride, but these are having lower chlorides. But still, they are higher than or high normal sites, and they are also acidic. Only this Plasmalite has got a normal pH, it has got a normal osmolality, and it has got normal sodium and even a normal chloride. So that is the choices. Problem is that most of the studies which have studied, they have compared sodium chloride in one side, and they have clubbed all of them together. So you don't have really good head-to-head trials between what happens if I choose between this, say, Hartmann solution or Plasmalite, or Linger's lactate and Plasmalite. We don't have studies to show that. So they have been clubbed as balanced solutions, and this one is unbalanced normal saline. So this is the list of the earlier trials. These are smaller trials. I won't go into the details, some 30, 40 patients or sometimes 18 patients, and different scenarios: open abdominal surgery, aortic reconstructive surgery, trauma, kidney transplantation. All of them, the comparisons were between normal saline, Plasmalite or Ringer lactate. I told you there was no choice between balanced solutions, were just clubbed together. And all of them, they showed that normal saline causes acidosis and hyperchloremia, and some of them they showed that they cause some amount of kidney damage. Hyperchloremia, hyperkalemia with this thing, acidosis, hyperchloremia, acidosis. So these are the initial trials, smaller trials, which showed the same message, the sodium chloride. But whether this is actually makes any difference, or it's only an early phenomenon that we were to see by bigger trials. So this is one of the earlier trials. This is a retrospective database from 100,000 US patients, critical care patients, and they showed that in 124 ESICs, the patients who are having tachycardia, at least one SIDS criteria, that is how they picked up the patient, that is, these are the septic patient, and received at least 500 ml of crystalloids were included, and the crystalloids were either normal saline and, as I've told you, clubbed balanced solutions. And here they showed that as the delta chloride, this is the initial chloride compared to the chloride at the end of the study period. So if there is an increase in chloride by 0 to 10 to 20, 20 to 30, 30 to 40, and 40 and above, the mortality goes linearly high. These are the confidence intervals, these two lines on the side. The main line is the solid line, shows the trend. And you can see this is just linearly related. So as much as the chloride the patient accumulates, more chance the patient will not survive. And this also showed the total chloride received by the patient and the total fluid volume received by the patient by 72 hours were all linked to mortality, higher mortality. Next, this was a recent trial. This is about 2018 trial, balanced crystalloid versus saline in critically ill patients. And it was a pragmatic, cluster randomized, multi-crossover trial, not exactly a randomized controlled trial. 15,000 patients, critically ill patients assigned to received either normal saline or balanced crystalloids. Again, it was clubbed together, Ringer lactate or Plasmalite A. Primary endpoint was any renal adverse event in 30 days. Secondary endpoints were death, new onset renal replacement therapy, new requirement for renal replacement therapy, or persistent renal dysfunction after 90 days. Patient outcomes, you can see that there was statistically significant more adverse kidney effects in 30 days with saline, in hospital death with saline, received a new renal replacement therapy with saline, and final there was no long-term defect between the two, and in hospital death too it was significant, but this ICU free days it was not statistically significant. So a clear message that normal saline is not good. You should switch over to this balanced solutions. They did not make any choice between the balanced solutions. And this was similar trial of the same year, that this was in non-critically ill patients, but this trial did not show any difference between the saline and balanced crystalloids. So possibly for stable patient, it does not make much difference. They handle them well. For unstable patients in septic shock or septicemia, the normal saline, particularly given over a period or excess normal saline, will definitely cause an increase in mortality, increase in renal failure. That was the message. And this was non-septic. This was in DKA patients. Again, it showed that when you use normal saline, both the patients, you can see that it takes more longer time to patient to come out of the acidosis part of the diabetic ketoacidosis. And bicarbonate level remains low in the sodium chloride group throughout the trial, both the trials. Problem is that we got a definitely clear message right now that we should not, we switch to balanced solutions, and the guidelines were also telling that don't use normal saline, use balanced solutions. Then we had this trial that is on 2022 March 3. And this was a proper double-blind RCT, smaller number but more stringently controlled trial. 5037 critically ill patients across 53 ICUs were given this balanced multi-electrolyte solutions or normal saline. Primary endpoint was death in 90 days, and secondary endpoints were need for renal replacement therapy and rise in serum creatinine. You can see that arterial pH, there was a drop in the saline group initially for first 3-4 days, but it caught up. After 4-5 days, it did not make any difference. Serum chloride, of course, in normal saline group always remained high. Then serum creatinine level, no clear message. Basically, it went on crisscrossing these two groups. And mortality, there was no difference in mortality outcome. I mean, at the 90 days. So again, a swing to the other side that we could not show much benefit by using a balanced crystalloid. And this was another 2022 meta-analysis. There have been several meta-analyses actually. One meta-analysis previously, I have not gone into all, showed that a clear winner for balanced crystalloids. The other one could not find any difference. And this is one very recent one they're seeing, and they have got studies with low chance of bias, and these are high chances of bias basically. But throughout them, you can see there is possibly a slight, this side is towards balanced solution, and this is the normal saline better. And you can see that there is a slight bias towards balanced solutions perhaps, but no clear message. And you can see there is basically all-cause mortality, there is possibly confidence interval is 0.96. Risk reduction is 0.96. And you can see that this is a high quality. And incidence of acute kidney injury is somewhat not moderate quality. New treatment with renal replacement therapy, moderate quality. So possibly some bias towards balanced solutions, but no definite clear-cut winner in this too. The guidelines, that is our surviving sepsis guidelines 2021, they made a change. From 2016 statement of that we suggest using either balanced crystalloids or saline for the fluid resuscitation of patients with sepsis or septic shock. They have changed it to for adults with septic or septic shock, we suggest using balanced crystalloids instead of normal saline. They have made a clear-cut recommendation that don't use normal saline, you use balanced crystalloids. But now with these 2002 trials, I don't know, maybe next to think they will again go back to the 2016 statements. The idea message is that we are standing at crossroads, not exactly, just it is to make you aware that fluids are not just fluids, they are also should be treated as drugs. There will be different situations. People with excessive, say, vomiting, diarrhea with alkalosis, normal saline would be a very good choice to give the patients. But maybe people who are already acidotic because of other reasons, and they have come to you, a balanced solution may be better, particularly on the second day, third day, for next 2-3 days after the initial volume. If you do not give too much of cumulative normal saline, that should be the message. So the take-home message is, fluid resuscitation is a component of complex physiological process. I've told you, we have not understood everything we are trying to understand yet. Fluid requirements change over time in critically ill patients. Specific consideration apply to different categories of patients. We must remember that a critical patient receives large portion of his daily fluid intake outside. That's also very important. We are talking about only that part of fluid, maybe resuscitation and maintenance, which can add up to maximum 30% of the patient's fluid intake. What we are giving with the drugs, what we are giving with the diet, that also remains important, and we should be taking care of that too. We should be careful about both the total volume of fluid given and composition of the fluid, especially chloride fluid to critically ill patients. I told you not only the chloride, the volume is also a cumulative volume, already pointed out by this earlier debate, that do not give uncontrolled fluid to the patients who are in septicemic shock. Assess well and then only use the fluids. And that's all. Thank you.
Thank you, Dr. Susruta, for that good lecture and keeping the time. You're spot on time. Thank you so much. We'll take the questions at the end of the section.